Next in line is our rapid fire presentations. And I know that several of our presenters are already in the room. I saw them earlier today. So we will start with Jennifer DuBose. Hold on one second, let me go back here. But before I turn over the mic to Jennifer, I was told to remind you that you can actually use social media to tweet and share some of the ideas from this particular event. So if Jennifer says some amazing things, make sure to tweet about them so everybody knows. Okay, thank you, Jennifer. I'll pass it.
Good afternoon. I'm Jennifer DuBose, and here's a picture of me at the end there in this very room at a Blue Sky retreat. So anyway, it was very appropriate that I use this photo. So I am a research faculty here at Georgia Tech and the College of Design, and I am the associate director of a lab called the Cemtegrate Design Lab, which is part of the College of Design. The director is standing there taking a picture right now, Craig Zimmering. And we are very well represented in the poster presentation, so I'm going to actually kind of give you a taste of some of those posters to hopefully entice you to go and talk to our presenters. So the mission of our lab is to transform the process of healthcare through the design of the built environment, and how can we use the design of the built environment, integrate that with the care process, and come up with better solutions that help improve the delivery of care. Right, so that's the vision that we have, and we've had the opportunity to work with lots of people in this room around campus, including ISYE and PNAR, and so it's great to be at a university where we have so many diverse skill sets that we can use, and so architecture is just one of those that we use in our toolkit. So these are the 4 basic things that we do, or how we kind of organize our work. So the first thing I'd say is we analyze problems, which is probably a pretty common thing to do here at Georgia Tech. But we spend a lot of time reading the literature, writing literature reviews, analyzing things, coming up with new frameworks and ways to think about how the problem of healthcare and the delivery of healthcare can be improved through our built environment and through doing that better. So we do a lot of publishing, and one of the big papers that's cited in the field is from 2008 that I worked on with Craig when I first started working on evidence-based design. We also conduct research. We have a lab in Tech Square, about 5,000 square foot lab for now, until they build a new high-rise there, where we do some really interesting work, and you should come and check it out. We have mock-ups, and I'll show you a few pictures in a minute of that. We try to speed up learning and innovation. So how can we find out what the better ideas are and the better ways of doing things faster before people start pouring concrete, before it gets built in place? And then how can we disseminate those lessons and get that out there? So how can we help this process speed up so we're not building based on what was great 5 years ago, but what's going to be great by the time the building opens up? And then we also develop guidelines, guidance documents, so we try to actually get that out into the hands of people who are going to use it. So we've done a lot of work with the military health system. We're hopefully going to be starting a project with the VA, so we can take these lessons and turn it into checklists and guidance documents so that it gets repeated again and again. So now I'm going to tell you about a couple of the projects that we did. We have been working with the CDC. The CDC funded a project with Emory and ourselves in Georgia State, and we have been working on how to improve the doffing process for treating Ebola patients. So this is the part that's the most dangerous. When you've been treating an Ebola patient, high stress situation, you're wearing this kind of onerous personal protective equipment, and you've most likely got Ebola on the outside of your suit. You've got to now take that off safely without contaminating yourself. So we actually went into the field, and we observed 41 training exercises where the healthcare workers did a simulated patient care task. They were infected with a harmless facsimile of Ebola. And then we watched as they went through this process, and we looked for specifically where they were interacting in the environment, where the environment seemed to be impeding their progress or seemed to be insufficient for steering them away from risky behavior. So we've been really careful to not say where we see people making mistakes, but where we see that they're doing things that could put them at risk, and how can we design the environment to kind of scaffold their activity so they don't do that. So we have a poster on that this afternoon, and I'll actually be presenting, well, on this and another thing in Phoenix at our big national conference in a couple of days. So this is our lab. and we built a biocontainment unit there in our lab, or room. We are not certified to actually treat contaminated patients. But so that's our lab, that's our biocontainment unit lab space. And we built out, what we did is, learning from those 41 observations we did of people doffing their space, we came up with what we thought was a better design, and we tested specific interventions, and we're able to find and make modifications on those. So this is that rapid prototyping, right? And tested it with students until we thought we had it right. Then we brought healthcare workers back in, and lo and behold, we actually improved their performance and reduced risky behaviors. So that's really exciting. We're just now processing the results on that, but we are excited to see that the built environment can, in fact, help people be safer. And hopefully that will translate into fewer self-contaminations and infections. So we have a poster on that as well. We have our third, I think, and final poster, or maybe we have 4 posters, is on the work that we've done around team rooms. We've done a lot of work looking at the layout of outpatient clinics and how that layout can improve the collaboration of the care partners. So the doctor, the nurses, the med techs, will they work better? Is their collaboration affected by the layout of the space? So these are some images of the floor plan, just to show you we really are architects, or we really have architects that work for us. I'm not an architect. But so these are space syntax diagrams that Raha can explain to you when you come and see her at her poster. But that show kind of the visibility and how visibility to exam rooms from team rooms can affect that collaboration and your ability to control the space, right? So can the RN be aware of what's going on in the clinic from their team room? So we're looking specifically at how the design is going to help that happen. And this is my last example I'm going to give you. Don't have a poster on this because this is just emerging, but very, very exciting work that we're doing. We officially announced the funding of this next week, but a collaboration we're doing again with Emory, funding a large donor, or a donor has promised a large gift to build a mild cognitive impairment program to help people with mild cognitive impairment, which can be the beginning stages of Alzheimer's. It doesn't always lead to Alzheimer's. But how can we help through the design of a better space and space in their homes, and how the space in their homes lead to a better experience? And we're also running an innovation accelerator through that I'm going to have the great pleasure to operate. And we'll be giving out seed grants on an annual basis, 3 seed grants, to work on things at the intersection of technology, the built environment, and therapeutics. And this is just an example of something that happened just up the street at the Aware home a couple of weeks ago. Really exciting. The older gentleman in each of these pictures has mild cognitive impairment, and they were working with a team of industrial design students to develop a teaching kitchen or a coaching kitchen where they could cook. And actually, the gentleman on the left is not a cook. He never cooked. And here he is with mild cognitive impairment, and he prepared a beautiful meal. He was so proud. So this is what we're considering empowerment. It's not that he's being cured, he's not necessarily treated, but he feels empowered. So we're hoping to do a lot more of these really exciting engagements with people through working with students and classes to come up with design solutions. So that's just a sample of the things that we have going on. You find these people in the room. Gabby is here in the back. She'll be doing one of the posters, and you can talk to her about how your students can earn $10 gift cards to participate in research in our lab. Ask her for more. Okay. Next.
So our next speaker is Danny Hughes. Do you prefer this one?
Mic'd up, so I think I'm good.
The other one? Okay, you are.
Fantastic. Let's see if I can get a slide up here. Fantastic. I am Danny Hughes. Can you all hear me? I think I can hear the echo that is coming to the speakers. I know they control the volume on these things. Okay, I'm a professor in the School of Economics and director of Georgia Tech's Health Economics and Analytics Lab, which I'll talk about today. I've just joined the faculty this August, so I've been here about couple months, which is why you'll note I'm using a generic Georgia Tech slide. We have yet to develop our own templates and slides, of course. We're still building up. But this is actually leveraged off of an awful lot of research over the past several years that I've been doing prior to arriving. And just want to spend some time today talking about this very exciting initiative, from my perspective at least, and how we can use this to leverage different kinds of interactions and different kinds of research across campus. So the Health Economics and Analytics Lab is the fruition of really a 5-year, $3 million partnership with the Harvey L. Neiman Health Policy Institute based out of Reston, Virginia. For full disclosure, I serve as executive director of that institute. So we can talk about what that means at another date, but at the same time, that institute is really dedicated to examining health policy problems, which is a little different from the sort of narrow clinical sort of problems, outcomes research problems that many of you are thinking about. But at the same time, it turns out that we've discovered in our research over the past 5-6 years that it's becoming increasingly important to have access to the same kinds of systems thinking, same kinds of analytical capabilities and tools that you would otherwise leverage in some of these other areas. Specifically, we're earmarked for the center here to examine things such as large-scale data analytics, machine learning, and artificial intelligence, which again, buzzwords everyone's using and everyone's playing with at every facet of health. But there's one important distinction with our center, and that's that we're doing this with a policy focus. So the traditional study that you might think of using these tools are, let's evaluate clinical pathways and see how we can optimize various patient treatments, or potentially look for ways to optimize turnaround times in a hospital suite, look for those types of efficiencies. That's not what we're doing. We're looking really at the systems level, the policy level. How, when you move from value-based payments to volume-based payments, how does that fundamentally change resource utilization, patient outcomes, and fundamentally even the profitability and sustainability of the organizations participating this on the provider and payer side. So leveraging large-scale data models to better understand issues. Studies we're working on would be things such as accountable care organizations. Are providers choosing to horizontally integrate or vertically integrate with many different specialists? And how does that change, again, their ability to make savings targets, change outcomes, alter research utilization? And we do this using large-scale databases. What we've brought in addition to funding this lab are really extensive databases of large-scale medical claims, types from CMS, for example. We have access to a 13-year panel of every medical claim associated with 5% of the Medicare population. Pretty large. More so than that, we have a partnership with OptumInsight for the next 5 years. We have access to every medical claim associated with every United Healthcare beneficiary and every large self-insured corporation that utilizes them to manage their claims. That covers 30 million American lives. So when I say large data, I mean very large data, large panels, terabytes and terabytes of patient-level data that we can delve into. And in fact, with our Optum partnership, we're now one of only 6 organizations that have access to the full database. And so that's something very exciting that we bring to the table in terms of how can we leverage this. And of course, partnerships with HCUP and AHA and other sort of large-scale databases available. But the sort of promise of what we can do when we're looking at literally millions of claims are the sort of prescriptive and predictive and descriptive analytics that everyone's talked about, but in slightly different ways. So for example, current projects we're working on, again, some of these come from an outpouring from previous research, but we're starting to build the linkages and working with probably 4 or 5 different folks here at Georgia Tech now, not counting the grad students we've picked up, to examine problems such as the Alzheimer's Foundation is funding a very large clinical trial right now called IDEAS, designed to come up with yet one more, can we definitively test for Alzheimer's? And there's different groups in the pathology world trying to do the same thing. But suppose we have that test. Who do you give that test to, right? Not everyone with dementia or cognitive disorders end up having Alzheimer's. What are the markers you use to determine the right guidelines for who should actually have that test? Well, that's where we leverage machine learning, artificial intelligence, deep learning within millions of patients over a fairly small panel, and try to understand, can we come up with nice heuristics that you embed either at the health system or at the payer level that flags these patients and say, maybe these patients should have that test. And then you develop the sort of guidelines that you would ultimately have, the kind of guidelines that were formulated for, say, mammography or other sorts of screening. So that's just one kind of project we're using where we're working carefully with ISYE and CS to try to develop the right type of algorithms we would have. Other sort of projects, you look at standard sort of evaluations. We had a recent study examining whether the annual wellness visit that CMS started authorizing for patients in 2011. Did that make a difference in the preventive care utilization? Why? Because that visit is not a physical. It was designed specifically to try to convince patients to meet with their providers and discuss exactly what preventive care they need and hopefully prevent downstream costs. Of course, it's a voluntary piece. Why is that of interest? Well, if you follow politics at all, you know that many specific procedures and components that CMS puts on the table are always up to date, really up on the table to be removed. And this is one of those procedures that's literally on the table, considered perhaps to be of low value. We perform a study and recognize folks who actually participate in those annual wellness visits increase preventive care utilization roughly 30 to 40% across a broad range of preventive services, everything from mammography to colonoscopy to eye exams, pap smears, et cetera. And so that's very important information, because once folks are thinking about potentially taking that off of the table, what happens to the potential downstream cost savings we have from that preventive care? So again, looking at a very policy-oriented approach to how we want to use and leverage this data to try to make a difference at a systems level within the healthcare system. What do we provide with HEAL? We're, again, this is the importance of having this presentation here today with this group. Many of you partners here on campus and away from campus. We just opened our doors. So we're looking for collaborators. We're looking for postdocs. We're looking for GRAs. I'm still staffing up the center. We're still getting our office space set aside, or else I'd show you a nice slide. But we're going to be set up at least for the next year and a half or so in the Habersham building. And we'll see if we move in Dakota or not. That's still apparently on the table with everyone in this room, I think, right? And so this hopefully I make it real of what we have in terms of dollars, opportunities for students and faculty member and data to collaborate on research. At this time, I should also note we have extensive collaborations with clinical partners. I'm actually an adjunct professor in the Department of Radiology at Emory University and have deep relationships there where I've worked with folks for about, I don't know, 6, 7 years. But we also have extensive partnerships, Mass General, Harvard. I'm actually, through my hat as executive director of the Neiman Institute, funding a similar sort of health analytics lab with Northwell Health and Hofstra University that's actually dedicated to clinical patient outcomes research, and actually sent an ISYE graduate student last summer there to directly work on the comparisons between different stroke pathways. So this is more traditional sort of comparative outcomes-oriented research where we're using their system-wide data to determine if a stroke patient arrives and has a CTA instead of an MRA, for which the guidelines are unclear, which imaging approach you should have to better guide treatment. Does it fundamentally change patient outcomes, readmission, functional mortality, and even the timing of when they have that image from when they arrive? And so that's somewhere else where we also operate outside of this space, but again, still thinking very much in terms of the systems level of how do we approach this. In addition, we see this as a foundation for additional research. We've actually already are a partner of a P30 center at University of Washington, which is funding musculoskeletal research, where we perform grants looking at dedicated clinical areas. And it's something that can leverage our retrospective data and databases to hopefully form that sort of, why is this an important study when you're putting forth your R1 or P30 grant for something a bit more focused in clinical. And at the same time, we have existing international capabilities, collaborations. We're working with folks at Taiwan, for example, where we're comparing our data with their data to examine, again, an important policy question. What's maybe something that's key with the current medical debate that we hear in the news? Medicare for all, right? Does that make sense? Does it not make sense? Well, Taiwan has Medicare for all. So collaborating with folks at Academia Sinica, we're comparing their patient panel of 5 million folks, which is roughly 10% of the Taiwanese population, maybe a bit more, to all of our databases, and trying to look at very precise clinical areas such as downstream mammography utilization and other clinical areas to see if the Medicare for all is fundamentally changing how patients and providers are utilizing resources, and then ultimately proximate outcomes like readmissions, mortality, and et cetera. So we can better evaluate what Medicare for all might look like, because they also have a fee-for-service national payer system that would be proposed if we chose Medicare for all here. So again, this is ways where you can leverage large-scale databases of the kind that are traditionally thought about from more of an engineering standpoint into what we think of as higher-level policy-oriented research. Thank you. No, no, continue with the question.
Because in looking at, workflow redesign, et cetera, if we're making changes from the payer level and telling payers to pay for certain procedures, but the workflows aren't really aligned to make those changes, then we need to look at all of those systems, across the board.
I don't disagree at all. I mean, I've done a little bit of research in the EHR space. I'll defer to folks who spend a lot more time there, but fundamentally EHR is a trickier concept because, there's 60 vendors, it's a competitive market, and without a world where we impose national standards, we're going to let the market generate standards, and I'm not going to weigh in, even as an economist, whether that's a good or bad component. And then you've got a market behemoth like Epic, which basically dictates what they want to do, and physicians sort of have to rely upon that. It's very tricky to say. We can design, and I'll just give an anecdote for that. So when I was at the University of Oklahoma several years ago, we had a grant to evaluate health information exchanges that we're trying to set up in the state. They were a Beacon Grant winner from the Office of National Coordinator of Health IT. And the folks in the state thought, well, we could come up with common standards, or I have a better idea. Let's have competition rule, and we'll set up 7 independent health information exchanges. That way, physicians can decide to use the health information exchange they want that conforms with the idiosyncrasies of their EMR systems, and then come up with a reduced set of common standards for them all to communicate, which of course meant literally patient name, not enough to actually make any meaningful decisions. The problem is, you can model that in an engineering framework and we can discuss it, but that's more of a political question. What is the growth, or what is the reach that government should have in terms of defining standards? And even the Office of National Coordinator for Health IT is not that very open. Let's let the users define standards, and hopefully we'll have a very quick convergence from VHS to Betamax into something that we love. Sadly, I don't think we're going to see that in health IT anytime soon. Is that an important component? Absolutely. My only real research, other than doing an evaluation of that program several years ago, was really looking at the degree to which health information sharing made a difference. And in fact, a paper earlier this year I had examining whether when folks shared laboratory tests, just something as simple as laboratory tests or imaging data between institutions, that mortality rates, it's kind of funny, right? Not funny, but kind of perverse. Mortality rates increased when they were sharing information between hospitals in a different network. So how is sharing additional data leading to an increase in mortality rates? And that's when you get into what's actually being shared. What is the quality of the information being shared? Are they simply not using it? And that's why we see an increase when controlling for different covariates. So I don't disagree at all. It's an important part of the system, but it's an important part of the system that has more part a political solution, part of an incentivized market solution, because it's the real solution to either have incentivized mandated standards that we feel are comprehensive, knowing that we have a lot of hospitals and that are already heavily invested in specific systems. We have a lot of vendors who are financially motivated to keep proprietary aspects of that sharing in place to maximize their market share. Or do we choose to reward natural monopolies or provide otherwise financial incentives for them to consolidate? Because ultimately, if they're sharing standards, there's probably not as much, as many ways to differentiate your product. And so you see a world where you actually have almost like in the internet space. We're going to have fewer providers, but much more even conformed products, as opposed to a lot of providers providing highly differentiated products. And so again, that's what's the right question there. And is it right when you move into that world as well? Because this brings it to another systems level policy thing I've spent some time on, and then I'll give someone else a moment. Sorry, Pinar. Well, let's catch up after this, actually. So. Sorry.
Is that on? Oh, wow. Okay. I almost feel like I probably should not use a microphone at all, but anyways, let's do it. So I also use the template Georgia Tech slides. I don't have the excuse of being new here anymore, although let's just pretend like that's why. Anyways, my lab is really interested in measuring and understanding parameters about the body using non-invasive sensing. So sensors that we can place, for example, in wearable devices outside of the body and learn things about health that could actually be relevant for making decisions. So maybe I'll start with kind of a question to you guys, since we have so many different people representing the different aspects of health systems here. How many of you think that current commercially available wearable devices are providing useful benefit from a clinical standpoint for patient management? I would say, for me, I would not have raised my hand. And I think part of the problem is what we're measuring with commercially available devices is not really that relevant from a clinical standpoint. And most of the devices are not FDA approved and not going through proper sort of validation channels. So I'm an engineer by training. I'm an electrical engineer by training, in fact. I came from a lab where my advisor was an MD, PhD, and so he was really instilling in us from the start this concept of clinical relevance. And so everything we do in my lab here, although we're in electrical and computer engineering, is focused on health-related applications. And very much at a scientific level, we're interested in better understanding what we're measuring from the body, and by doing so, how to better exploit those signals that we're measuring to learn things that actually matter from a clinical standpoint. So one of the projects I've been fascinated, and this is a rapid fire, so you're not going to get any in-depth information about how these things work now. But if you have any questions and you want to chat with me, or if you want to check out our papers, if anyone actually does that, then that's, of course, those are the real options. So one of the things I've been fascinated with since I was a grad student, actually, was this concept that every time your heart beats, there are mechanical vibrations and movements of your body that occur as a result of the heartbeat. Of course, if you put your hand on your chest, you kind of already know that. But many people don't know, for example, if you stand on a weighing scale, your body weight actually fluctuates by about 0.1 pounds every time your heart beats. And that's because of the fact that the center of mass of blood in your arterial tree is moving slightly up and down. And my lab has been measuring and learning more about that signal. It's a signal called the ballistocardiogram. It was first discovered in 1880s. It was first measured using these tables and giant beds in about the 1930s and 40s. So in my PhD work, I showed that an ordinary electronic weighing scale could basically be hacked and used to measure these signals reliably. And I started discovering that things like changes in cardiac output, which are useful parameters, especially for managing and understanding heart failure patient status, could be measured with the scale. My lab here at Georgia Tech now is working on wearable measurements of these vibrations using accelerometers on the chest. So some of the work that we did recently showed that, for example, you could detect essentially the compensated versus decompensated status of heart failure patients using some of these measurements, especially before and after some exercise tests, like a 6-minute walk test in particular, and that you could track heart failure patients in the hospital from admit to discharge and notice that through this signal there were substantial changes, significant changes from a statistical standpoint that preceded other things that are more commonly measured, like heart rate related parameters as well as sort of walking distance. Oh, what did I do there? Whatever that button was should never be pressed. We've been doing some work for the past 4 or 5 years now through this large collaborative network funded through NIH focused on cuffless blood pressure measurement. Again, we're using these vibration signals to understand when the aortic valve is actually opening, when blood is first pushed into the aorta, and then to use that and some timing of specifically how long it takes the pulse wave to travel through the arterial tree from a proximal location to a distal location to detect blood pressure without the need for a cuff. We're still dealing with many problems in this project, but we've shown some promising results so far with a wrist worn as well as, again, a scale-based prototype. And this is ongoing work in the lab. Separate from this cardiovascular measurement work, over the past few years, totally by accident, I started getting excited about the sounds emitted from the joints. After finishing as a grad student at Stanford, I started working at this pro audio company where we built microphones that had much better high frequency response than this one that I'm using now. And so I had learned how to basically build miniature microphones for Broadway singers, for rock musicians, and also for basically hiding and clothing for TV shows and that kind of thing. And so when I first started here, I started thinking about why don't we put these around the knee, which, why would we do that, right? But maybe to be able to understand some structural abnormalities, or to see if somebody, for example, rehabbing a knee injury might be at some points ready to move from one particular sort of activity to another during rehab. Since then, because of this cool Georgia Tech Children's Healthcare of Atlanta partnership, we got connected, my lab got connected with some pediatric rheumatologists there and realized that maybe these signals that we're measuring for athletes after their injuries to see if we can track their rehab status could also be useful for patients with juvenile arthritis, where it's a heterogeneous condition. It's very difficult to understand which type of medication is going to work well for which patient, and where you have to wait for months and use symptoms and pain and these sorts of subjective criteria to determine if a particular medication is working or not. So we're really interested in seeing if the sounds from the joints have particular signatures and patterns that are representative of the state of patients with arthritis, to see if the joint is inflamed, for example, does that change the sounds that we measure, and to use that maybe as a physiological biomarker that could help with the process. We've also been doing some more basic studies. So again, we do sort of full spectrum from boring sort of engineering work all the way to clinical work. And part of that is really trying to understand these signals better at a fundamental level. So we do some work here with cadaver limbs that are used, the same kind of limbs that are used for orthopedic surgeons in their training. So fresh frozen limbs that preserve the mechanical properties of the joints and the tissues. And with these limbs, actually, I have a student who's an MD PhD student, again, through this collaboration with Emory, who can induce a meniscus tear, perform different surgeries on the limb to see exactly how, again, the signatures of these sounds change with those surgeries. We've had some really exciting results with this that have shown that some of the same sorts of algorithms used, for example, for analyzing acoustic emissions from structures in civil engineering can also be used to analyze the structural integrity of knee joints. So that's been exciting. And just one other project to briefly mention, we have this Defense Department funded project which is focused on trying to come up with a non-invasive and hopefully more effective than pharmacological approaches therapy for patients with PTSD. This is again in collaboration with Emory, psychiatry, radiology, and cardiology. And we've had some really promising results using this non-invasive peripheral nerve stimulation device at the same time as a patient receives a recall of their traumatic event. And it's essentially this interesting sort of neurophysiology behind that that essentially blunts the sympathetic fight or flight response to that normal sort of stimulus that would normally elicit that. And so I have a fantastic team here of, I guess now, 19 PhD students working on this work, and research engineer and funded through a variety of course, sources that are generous. And in this Georgia Tech collaborative environment, of course, we've got a lot of great folks that we work with. So thanks for your time. Thank you. Oh yeah, sure. Yeah, sure. I'm trying so hard to stay on time that I forgot that I have time for one question. I was at a panel once where please say your name and one sentence about your research turned into 20 minutes per person, so. Great, thanks, Jeff.
Thank you so much. Okay, our next speaker is Ziha Lee. So Ziha is a former PhD student who is currently at the CDC.
Hi, good afternoon, everyone. My name is Ziha Lee, and as Pinar said, I was actually working with Pinar at Georgia Tech for my PhD degree in industrial engineering, and I just graduated last year and joined CDC as a prevention effectiveness fellow at the Centers for Disease Control and Prevention. And actually, I'm in the division of HIV/AIDS prevention, and our team is called Prevention Modeling and Economics team, where we actually develop mathematical modeling for the entire division to estimate cost-effective. We perform cost-effective analysis based on these mathematical models and test out the different interventions. Obviously, I'm only a small part of the CDC, and I'm only at the HIV and AIDS, and all of my projects are related to that. There are other parts of the CDC that does awesome work, and they will be willing to collaborate with anyone sitting here, if you're interested, I guess. Okay, so the primary goal of our team is to apply quantitative science to prevent HIV infection and reduce HIV-related illness and death. We focus our work on estimating the cost effectiveness of prevention efforts such as HIV testing, care and engagement retention. And one of the major breakthrough in the HIV field was the antiviral therapy, which is in 1996. And we have been using this drug to suppress the viral load of HIV for people who are infected with HIV. And we usually you think this will be treating sick patients, but actually having people under their viral load under control is actually a very effective prevention policy because it prevents the transmission of HIV virus. In recent years, we also were investigating the effectiveness of pre-exposed prophylaxis. This is basically having people not infected with HIV to take the drugs so that they won't not be getting infected. We also analyze some of the behavioral interventions where people will tend to be engaging in less risky behaviors. So to kind of figure out what will be the best way to prevent HIV, we developed several mathematical models that are mostly in the simulation area. So one of the models we used to estimate HIV transmission rate was a agent-based simulation model. We call it the progression and transmission of HIV, or PATH. So basically, it tracks the disease progression, treatment, and transmission of HIV at an individual level. It also simulates the sexual and injection drug use partnership from between people who have HIV and people who don't have HIV to estimate the transmission dynamics in the United States. And we usually divide people into subpopulations based on their population risk group, whether they are men who have sex with men, people who inject drugs, or heterosexuals. And also, we incorporate the HIV care continuum based on the treatment options each of the individual have, and we divide them into age group. In recent years, we have seen, because of the HIV drug are getting better and better, people are living with a longer life expectancy, so there is an increased effort in researching the different interventions for people who are with age more than 65 years old. Using this agent-based model, we were also able to replicate some of the transmission networks features and clustering in our national HIV surveillance systems, where we see a lot of the infections are happening at the same place and with a clustering effect. So you will see a huge cluster of 100 people that were mostly infected in the last 6 months to 1 year. So we were able, so what we're trying to do now is to use our simulation model to replicate that feature and test out cluster-based interventions in, and hopefully we can use that whenever there's an outbreak of HIV in the future. So another kind of model that we are using is more population-based. So basically, we divide people with HIV and without HIV into different compartments based on their age group, risk level, transmission group, sex, and race and ethnicity. And each of the compartments will have the number of people flowing into the compartment and number of people flowing out of the compartment. And we're using a system of differential equations in MATLAB and solve them to monitor what will be the dynamic of HIV transmission maybe like 20 years later, 30 years later. So the two projects we're using this compartment for are assessing the effects of reaching national HIV/AIDS strategy goals. I'm not sure that goal is still in place. And we're also analyzing the cost effectiveness of different interventions, including increasing HIV testing frequency, increasing adherence to HIV treatment, and increasing the coverage of prevention drugs. And finally, we are using all of these models to estimate HIV dynamics. And some of the times, as a federal agency, we allocate fundings to state and local health departments, and we want them to use this funding wisely. So we develop a Excel-based tool for the state and local health departments to allocate HIV funding to each of the intervention programs that we recommended. And the input to this model are related to the efficacy of each of the individual programs and the clinical data specific to the states. And we put a budget on for each of the states and use a optimization model and help the states to solve for their individual states' parameters and obtain a optimal funding strategy. And we're trying to test it in-house at CDC and hopefully push it out for State Department to use later. So obviously, we are still in a very early stage of developing these models, and we are partnering with university professors and research institutes outside of CDC, and sometimes the team will give funding out to develop some of these mental models. So we welcome any collaboration efforts with our team, and we look forward to it. And that's all for my talk, and any questions?
It seems that a lot of the work you're doing is generic in the sense that it could extend to other illnesses. What about something like seasonal flu?
Yes, so HIV transmission has a dynamic that it's both a infectious disease and also a chronic disease. I think for influenza, we don't really require partnership. So in my own idea, I think HIV modeling is a little bit harder than influenza in some sense because you have to capture this network effect. Whereas in influenza, you can have you can transmit to everyone that you contact with. So I guess modifying the contact network could result in a different model in simulation that could be that could work out for influenza. Yes. Any more questions?
Our next speaker is Mark Styczynski, and I am sorry if I didn't pronounce your last name correctly.
I'll see if this one
Oh, you want to
works
try this
easily.
one?
Hello? Great, cool. All right, so thank you, Pinar, very much for the invitation to tell you a little bit about the work that my group is doing in terms of developing low-cost, equipment-free, low-volume, and quantitative diagnostics. So it's a big old mouthful, but hopefully I can convey to you kind of why this big part of our lab is important and what we hope to be able to accomplish in the near future. So when you think about medical diagnostic tests, it's quite possible that you might think of some things like the following: potentially big needles with blood draws, trained lab personnel that have to go and do this complicated test, potentially on some very expensive, fancy lab equipment that not everybody can afford. And then you wind up waiting days to get your results. When you finally do get the results, eventually you'll get potentially a very big bill for them, right? So that's kind of what I think of when I think of medical diagnostic tests. And our goal in a bunch of the research in our group is to try and turn a bunch of that on its head. So we're trying to develop diagnostic tests that can use drops of blood so that you can maybe get it from a finger stick. And that can have really significant ease of use, right? To the point that almost like a blood glucose monitor that a home user could potentially be able to execute some of these tests. But perhaps different than a blood glucose monitor, we want to have things that don't actually require analytical equipment, because there are a lot of cases where even relatively inexpensive analytical equipment might be out of reach for a lot of different people. We want to get visible readouts in a very short period of time. And that's kind of where we come to this idea of no analytical equipment, is that if we can get visible readouts, that we might have something that moves from like this blood glucose monitor to something that's like a pH strip, where you can just look at individual colors and you can have an idea quantitatively of what the reading is for that individual target that you're trying to measure. and then ultimately low costs, right? So to go from tens to hundreds of dollars to tens to maybe hundreds of cents. So that's what we're trying to do. And kind of the initial motivation, we got pulled into this area of work by the Bill and Melinda Gates Foundation. We got a little seed grant, and we were, oh, excuse me, I'm recovering from something. Oh, all right. So our original motivation when we got pulled into this was looking at vitamin and mineral deficiencies in the developing world. And so I'll talk to you a little bit about zinc deficiency. And so here we have a map that is really a very basic kind of third order general estimate of the prevalence of zinc deficiency across the world. And so as you can see, first of all, there are different areas that have different prevalences. You'll see that the areas that have the biggest problems are typically the developing world. And if you look specifically at zinc deficiency, it kills 100,000 children under 5 every year across the world. But the problem is that the aid agencies that are going to try and fight this problem, they don't have the data that they actually need in order to attempt to make this fight. So I told you, these are kind of like third order, very rough estimates. And they don't have the kind of resolution, they don't have the kind of accuracy that an aid agency that, like the USAID, could go in and say, well, I know that in this country, that specifically one subregion is where we need to devote our efforts, right? And for these aid agencies that do have very limited resources, they need this information in order to allocate those resources effectively. And the reason why they don't have this information is these diagnostic tests are just really too expensive and too logistically difficult to perform at the scale and in the locations where they're most needed. So I've already highlighted that the developing world is where most of these problems and nutritional deficiencies exist. And in the developing world, you not only will typically not have access to a fully staffed and equipped clinical lab, often you might not even have access to electricity at or near the point of care. And so it's important for you to develop extremely low cost, equipment-free, electricity-free approaches to take these measurements. Now, that's one motivation, but health disparities exist at home too, right? So across the United States, based on your zip code, you will have a different adjusted estimated life expectancy. And this is perhaps due to unequal access to healthcare, but perhaps also when people do have access to healthcare, uneven quality of healthcare, right? Because somebody who is going to a rural physician's office where they might not have the equipment necessary to do one test, or when they take the test that they might have to send it very far away and pay a lot of money that they otherwise don't have in order to get the kind of test readouts that they need. And so my question, kind of my motivator here is that if we had more of this diagnostic information, could we do a much better job in these low-risk areas? If we could provide them with low-cost things that they could do in these potentially remote or underserved offices, could we do a better job helping these folks? And so our vision to do this is what I say is cheap, easy, equipment-free biosensors. And by biosensors, I mean that what we start with for the nuts and bolts and guts of our work are these microbes, these bacteria that are otherwise harmless. And the first thing that we do to these bacteria is we bust them open. And we take away their cell membrane, and we use the stuff that's inside, which is really valuable and can do lots of interesting things. And so we take those insides, and then we add some genetic program to it, right? So we can take different pieces of DNA, and we can add them to this now in vitro mixture, and that mixture can then be programmed to perform different functions, to sense different things, and to make different outputs. And so what we then do is we can put that combination of our cell-free lysate plus that DNA program onto these different spots, right? And so this could be maybe spots on a piece of paper. This could be different tubes that are all nearby each other. And then the vision would be that you can take your blood sample and to each of these spots, and what you'll wind up with is really a customized calibration for your specific blood sample, where just like that pH paper that I pointed to earlier, you're gonna have these different calibration spots where you can just look at that bottom spot and immediately tell what the quantitative value is for the thing that you're trying to measure. And we've done this, right? So this isn't pure fancy. This is an actual zinc in vitro cell-free transcription translation diagnostic that we've now developed, where you can see these are the calibration spots that were all run in the same specific blood sample. And then you see that these are individual measurements where we spiked in different levels of zinc, and you see that the colors do indeed match up exactly how they're supposed to be. Right? So we've got this working for zinc, and of course, our goal is to get this working for more things that we can then deploy across the world and hopefully across the country. And I want to point out that one of the valuable things here, so I've already said that this is a completely equipment-free, measuring zinc, and using microliter volumes of blood. We actually resuspend each of these with anywhere from 2 to 8 microliters of blood. And it is a generalizable approach, is really important. So remember earlier I talked to you about those DNA programs that we're putting into the cell-free lysate. So those DNA programs, we can change out what's in them. We can change what different sensors are that are inside them. And so as long as you have access to those interesting, unique, and useful different proteins, transcription factors, or other nucleic acids, that you can make something, in theory, to detect arbitrary biomarkers. And then also importantly is something called matrix effects. And this is kind of maybe a higher order thing that maybe the analytical chemists among us might really care about, but these are actually a really big issue. So fundamentally, my blood does not look the same as your blood. And actually, to be really specific, my blood does not look the same as one of my graduate students' blood. She spun it down and her blood serum was really bright yellow and mine was not at all bright yellow, right? And that's due to differences in the bilirubin levels. But the point being, each of our blood matrices ultimately are fundamentally different, and that can change the output. So if we're then trying to measure zinc, all of those other things can change the perceived measure of zinc that comes out of your diagnostic, that comes out of your measurement. And something that's super simple and equipment-free like ours is particularly susceptible to this problem. But you remember earlier what I described, we actually take the same blood sample and run it in both our calibration spots and our test spot. So we actually remove that matrix variability, and this makes it then much more generalizable so it'll work for potentially anybody's blood sample. So this is a big goal in our group, is to develop these equipment-free, low-cost blood tests. And so if you have any interest, I've kind of really buried the science here. If you want to know anything about the science, please come find me after. Or if you have visions for things that you would like to measure, or maybe how this could be used, then please also do come find me, because I'd love to hear what you have to say. Of course, thank you to the people that actually do the work. Monica and Daniel were the people that have really driven this from nothingness into something that we hope will actually go out and impact the world. So thank you very much for your attention, and maybe I have time for a question? I don't know. Okay, sure.
So you mentioned it was generalizable. You mentioned
With work, right? I mean, it's not just like, boom.
Okay, no, I
Yeah.
get that. And you mentioned DNA. What about RNA?
So you mean in terms of things that you want to detect?
Yes.
Okay, so funny thing.
Particular biomarker that we're.
Yeah, so the funny thing is that the RNA problem is actually more solved than some of the things that we're trying to address. We've been addressing small molecules. The important part is then if you want something that's quantitative, like if you're looking for viral load, that's where what we've come up with, this quantitative aspect, is really important.
So I'm going to email you, Sherry Ferrucci, and please don't ignore me.
I know exactly who you are, Sherry. I've been dying to talk to you sometime. Hi. Yeah, so that's an amazing and insightful question. So the question was specifically for zinc, what do you do when you actually get this information? And so that's kind of a difference maybe between what we would do with zinc and maybe with the RNA biomarker that Sherry just asked about. So for zinc, actually the way that this is addressed is on a population scale. So nutritional deficiencies are typically endemic to a region, not a person. And so when USAID or somebody like that swoops into a region, they'll actually treat a whole town, a whole region with a supplement rather than individual people. So what they're actually looking for is, can they take a statistical subsample of an area, get that information, and then act based on that. So for them, it's not going to be a one-to-one, although getting those results quickly is extremely useful for them. So they act on an epidemiological level. But I can envision other applications of this that are more in the clinic where you could get that one-to-one interaction. Cool. Thanks very much for your time.
Once again, to all of our rapid fire presenters, this was amazing. Most of this information, even though I'm at Georgia Tech, was new to me. So, and hopefully you all enjoyed it as much as I did. So you may have noticed 4 out of 5 rapid fire presenters were Georgia Tech faculty, but they all came from different units, different colleges. So that's by design. One of the goals of this event is to expose the audience to all the great work that's happening at Georgia Tech. Each of the professors very, very enthusiastically talked about their students, their team, So we have several students in the room, and really our students are truly amazing. We couldn't be luckier to have them here at Georgia Tech. They really, really help progress our research and impact in society. So we are grateful to have them here. One of the rapid fire presenters was an alum, and we actually will have more alums in the audience, and we will have some of them in our panel discussion later. So when they graduate, our students go out to the world to do amazing things, and they also come back and continue their commitment to Georgia Tech, to our education and some of our other activities. So we are truly grateful to them for keeping this connection and for continuing to support us and all of our activities here.